Well, good morning, everybody. I'm going to take the pleasure of giving you folks a lecture today on Petrous Apex, and I kind of call it the difficult reach because the Petrous Apex is truly a anatomic structure of the temporal bone that is beyond the reach of many of us. Fortunately, the pathology that does occur there is rare, um, and hopefully through the course of this lecture, you will pick up some really important points that will help you understand the Petrous Apex and its role in ear disease. I think the first place to start is with a little history of the Petrous Apex, um, and that is Meckel. Meckel was a German anatomist. He comes from a family of 4 or 5 German anatomists, and in the late 1700s, he was the one who described the Meckel's cave, which is the anatomic boundaries or the dural envelope that encompasses the trigeminal nerve. Then in about 1859, Wenzel Gruber described what is considered to be the petrosphenoidal ligament, the ligament that goes from the greater wing of the sphenoid to the petrous bone. And its importance is that underneath this is the abducens nerve. Perhaps the most famous person of all, especially if you were living in the early parts of the 20th century, would have been Gradnigo, who was an Italian ENT. And in 1904, he wrote a paper describing some of the complications of otitis media and mastoiditis involving the Petrous Apex. And fortunately, this rare lesion, which was common before antibiotics came into play in the late 1930s, early 40s, was a very life-threatening illness. He's known for the triad of otitis media, abducens nerve palsy, and retroorbital pain. And last of all is Dorello, who's the Dorello's canal, which is the abducens canal, was named after him, and he wrote a paper in 1905 describing this. So that's a little of the history behind the history of the Petrous Apex. In this lecture, some of the goals will be to discuss some of the regional anatomy, looking at air cell tracts, pneumatization, symptoms, CT and MRI, working on differential diagnosis and different surgical approaches. In this slide here, you can see the temporal bone. The colors here, we have the squamous portion, the mastoid portion, and the Petrous Apex, which is the zone that sits anterior to the cochlea as well as the internal auditory canal and is encompassed by blue here. In this image here, we can see the bone has been stripped away. We have the internal auditory canal, semicircular canal, vestibule, and cochlea. And this is the region of the Petrous Apex, which houses the carotid artery. And this image here, which looks at the osseous structures of the temporal bone, we can see the internal auditory canal, and just anterior in this zone here is the Petrous Apex with the carotid artery in that location. There's a couple of fissures which are important because the anterior portion of the Petrous bone, in particular this portion of the apex, there's 2 important fissures. One, the petroclival fissure, and the petrosphenoidal. The petrosphenoidal is right here, and the petroclival right there, this being the clivus bone and the greater wing of the sphenoid. Really important is to understand what is the makeup of the Petrous Apex. 60% of the Petrous Apex bones consist nothing more than bone marrow. Another 33% are purely pneumatized. And about 5 to 10 of the percent of those are asymmetric pneumatization. And a very small percentage, about 7% of the Petrous bones are sclerotic. So we can look here and we can see examples of all three of those. The bone marrow or the fat, which is a normal variation, including about 60% of the population. The pneumatized, lack of air cells, and a complete aeration of the Petrous apex is about 30%. And sclerotic, where there's no air cells and it's pure solid bone, is very low, 7%. This, the pneumatized Petrous apex, is the one that we need to focus on because this is the one that will develop pathology. This one has associated air cell tracts that come from the middle ear and the mastoid and can contribute to the underlying pathology that we see in the Petrous apex. Now here you can see, even though this is an artist's rendition, here's our mastoid air cell complex, the cochlea, semicircular canals, and the Petrous apex. What's important is it's these tracts that go superior to the superior semicircular canal between the rims of the superior semicircular canal, underneath the cochlea, and underneath the labyrinth that lead to the apex, because these are the routes by which, or the pathways by which pathology develops in the Petrous apex. Middle ear pathology and mastoid pathology can travel along these pathways to the Petrous apex. I think also it's important because this area, as I said, is a difficult area to understand, but if you take it in the context of it's nothing more than an anterior complex of air cells, you'll be able to appreciate it a lot better. Now, in association with the Petrous apex, we have the middle cranial fossa, because here's the Petrous bone, the apex lies right here. We have the middle cranial fossa, the posterior cranial fossa, trigeminal nerve, abducens nerve, the clivus, and the greater wing of the sphenoid. These are the anatomic structures that are associated with the Petrous apex. Now, I thought this was an interesting article because it talked about the differential diagnosis of Petrous apex lesions. It came from the House Ear Clinic, which is probably the at one time it was and still maintains a significant reputation for not only training in otology or in neuro-otology, but for writing a significant amount of papers in the that talk about all kinds of pathologies and is very academically oriented. So they did, this is Dr. Brackman and Dr. Arriaga, 1981 to 1991, a period of 10 years. And what they used was their reference. In this 10-year period, they saw 1,500 patients with acoustic neuromas, okay? 1,500 patients. In comparison, cholesterol granuloma, they only saw 40. This is cholesterol granuloma of the Petrous apex. Cholesteatoma of the Petrous apex, they only saw 5 of them in a 10-year period. That's 1 every 2 years. And a mucocele in only 1 case in 10 years of Petrous apex lesions. So you can see that in comparison to acoustic neuromas, cholesterol granulomas are very rare. Now you can also get cholesterol granuloma in the mastoid. If you've done enough surgery, you'll find sometimes you'll see this granulation tissue with old motor oil. It's the best explanation I can give you. And those are small cholesterol granulomas in the mastoid, but they're quite different from Petrous apex because they don't create a mass effect, as we see and we'll talk about shortly as in the Petrous Apex. This is another article from the House Ear Clinic, written in 1998. And it was a review over a period of 20 years, retrospective, and they had 66 patients with Petrous Apex lesions. And the interesting thing is, well, what are we going to see as clinicians in terms of the patient presentation? Well, of these 66 patients, 64 presented with hearing loss. Well, we've got a lesion at the apex. Why are we having hearing loss? Is it because the mass effect of the lesion is blocking the eustachian tube? We're getting middle ear pressure, middle ear effusion. We're getting possible erosion into the cochlea or destruction. Those are probably the causes for this hearing loss, okay? As you can see here, only 6% presented with otorrhea. So we're not seeing patients like they saw at the turn of the century, and as described by Gradnigo, with otorrhea, pain, and abducens palsy. Those, if you see a patient like that, take a video and document it, because in today's day and age, it's not the most common presentation. So hearing loss, dizziness, headache, and tinnitus were much more prevalent in this large series of 66 patients. We have also, we can look at the pathologies. As I said, cholesterol was the #1 pathology, followed by cholesteatoma and mucocele. This was another paper from the House Ear Clinic. And these were the cystic lesions, the solid tumors. The #1 was a chondrosarcoma, which is the #1 malignant tumor of the Petrous Apex, primary tumor. The most common metastatic tumors to the Petrous Apex are either prostate or breast cancer, which can metastasize to the Petrous Apex as well. But the most important thing is the #1 pathology of the Petrous Apex in a cystic lesions is the cholesterol granuloma. Radiology. Well, the CT scan and the MRI are critical. You cannot have just one or the other. They are both needed for diagnostic purposes, and they're complementary to each other. And they support not only the diagnosis, but also the surgical approach. And we'll talk about that in a few minutes. This is a great chart. I think the key to this is whether or not, and then we're comparing CT scan and T1 and T2 MRI. Here's the pathology. And I think the most important thing is to look whether or not there's enhancements with gadolinium. You can see that all these benign cystic type lesions do not enhance at all. However, when we come down to metastatic lesions and the #1 carcinoma, primary carcinoma of the Petrous Apex, we get enhancement. So anytime you have an MRI which shows enhancement with gadolinium, you have to think of a malignancy. And it's going to be important to differentiate here between Petrous Apex bone marrow and Petrous Apex cholesterol granuloma. The Petrous Apex, when we talk about just normal marrow, has a significant amount of fat in it. So if we do a suppression, fat suppression, and remove the fat, we will be able to delineate whether or not we have a Petrous Apex, marrow we're dealing with, or a granuloma, because they can look very similar. And here's the images that we need to look at. These are CTs, okay? Here is our axial view, and here's our Petrous Apex. Again, if you go down or up, depending upon what level you start at, you'll see the carotid artery here, and here's our apex. seems to have it's isodense with the brain at this point. This is most likely just bone marrow. And again, you can see, let me just shut this off for a second. It said I had an unstable computer here. Okay. All righty. So here you can see, here's our cochlea, internal auditory canal, and the vestibule. You can see how the Petrous apex is anterior to the cochlea, anterior to the internal auditory canal, and it makes up this very difficult area to approach. On our coronal view, we can see we're anterior. Here's the condyle of the mandible. And we can see here's our eustachian tube with air in it, carotid artery, and the bone of the Petrous apex and the clivus. Okay, these are standard views, and we need to look at these. This would be, if you're going from anterior to posterior, this would be cuts in the anterior part because the Petrous apex is anterior. As we go posterior, we'll pick up the middle ear and then the mastoid. And the same thing here. As we cut through from superior to inferior, because that's the way I like to look at it, we'll see the superior semicircular canals, pick up the air cells of the Petrous apex, start to identify the carotid artery, and then lower down as we get towards the basilar turn of the cochlea and just below, we'll pick up the jugular bulb, which is a very important structure for the not only for identification purposes, but for surgical planning. Because if you're going to attempt an infra-labyrinthine approach to the Petrous apex and you have a very high writing jugular bulb, you're not going to be able to use that approach. And you'll probably have to use a infra-cochlear approach or middle fossa. We'll talk about that shortly. I think it's important to look at some of these MRIs. Again, here's our standard T1. This is a cholesterol granuloma. You can see it enhances on T1 here. On T2, it enhances. And with fat suppression on a T2, it remains enhanced, which makes the diagnosis of a cholesterol granuloma. If this turned dark with fat suppression, it would mean that it would be marrow. And I'll show you that in just a second. And I want to just talk for a second about the pathogenesis of cholesterol granuloma. Basically, there's numerous theories out there, but there has to be some form of at least hemorrhage. Whether or not it's due to air cell blockage or another etiology, it all results in hemorrhage in the Petrous apex air cell complex, followed by a foreign body reaction, and ultimately the formation of granulation tissue and this like motor oil fluid. So this is the pathology of or pathogenesis of cholesterol granuloma. Now, if we're going to look at bone marrow, this is basically what we're looking at. Here's a T1. You can see we have a nice signal here. T2, we see the same thing, not as bright. And now we're going to do a T2, and we're going to strip the fat out of it, and you can see that the lesion's not appearing. So this is a good way to differentiate, as I said before, between the cholesterol granuloma and bone marrow. Mucocele, if you remember from that study for over a period of 10 years at the House Ear Clinic, they only had one mucocele. Okay, remember, very rare pathology. So on T1, we have a lesion that looks like it's a little hyperintense. T2, similar. And with gadolinium, we're getting no enhancement, which is exactly what we need to see. If this thing enhanced, then we would have to think possibly of a tumor or a malignancy. Remember, on MRI, if you get enhancement with gadolinium, you have to think of a malignancy. And here's a perfect example of that. This is a chondrosarcoma. I had a lady with a chondrosarcoma of the sphenoid sinus. We did a frontal craniotomy with the neurosurgeon. We did a degloving and a transnasal removal of the tumor in combination with the neurosurgeon endoscopically. And this lady is now, she had proton beam, she had positive margins, even though she had positive margins even after resection. She had conventional and proton beam radiation therapy. She is now approximately 25 years post-op with no recurrence. So you can see here's the chondrosarcoma. It's on a T1 image. This is a right side. You can see the tumor here. We'll add some gadolinium, and you can see we're getting enhancement. We're getting compression of the brainstem. And you can see on T2, we're also getting a high signal intensity. So let's talk about surgery. Okay, we've hopefully got a good feel for the anatomy. We've got an understanding about the air cell complexes. We have a feel for the role of both CT and MRI and the use of contrast and the importance of contrast and the need to ensure that we're differentiating fat from a lesion by subtracting the fat subtraction or fat suppression, depending upon which term you're using or the radiologist use. So how do we get here? How do we get to the apex? Well, there's an anterior approach, anterior skull base called the transsphenoidal. And we're gonna have a lecture August 4th by Dr. Solaris from Emory University School of Medicine. He is a skull-based surgeon, ENT, and he's gonna take us through the anterior skull base as the approach to the Petrous Apex. Anterior lateral, I can't talk much about this because I've got zero experience or knowledge about it, but I can talk about the lateral approach, the lateral skull base approach using middle fossa, infra-cochlear, and infra-labyrinthine. A lot of words, a lot of stuff to know here, but I'll try to make it simple for you. First of all is this, let's look at some of the demographics and statistics on these lesions before we proceed. Majority of them occur in younger people, okay, 14 to 62. We're probably not seeing a higher or an older population because by the time they're diagnosed, depending upon the pathology, especially malignant tumors, a lot of these patients aren't surviving, okay? But when these lesions develop and become symptomatic, people aren't going to sit around with headaches, you know, and hearing loss. They're going to get treated. It's about equal right side, left side. And it's interesting that male to female ratio, it's about almost a 2-to-1 male to female having lesions of the Petrous apex. And the number one approach that was used was the infra-cochlear approach. Now, if you remember Dr. Hoa, he gave us a lecture on cochlear implants. Agata, if she's there, she is familiar because Dr. Hoa, who, as I mentioned just a second ago, he's the one who wrote this article when he was doing his fellowship. We can also look at another study. This was done also by Dr. Antonio de la Cruz. It encompassed 66 patients, and they looked at the various procedures, and infra-cochlear was, but wasn't much more, but it was 12 to 11 in terms of infra-cochlear, infra-labyrinthine. And why the difference? Most likely it has to do with the position of the jugular, or excuse me, of the jugular bulb, because the jugular bulb will predicate whether or not the infra-labyrinthine approach is a viable approach. So here we have two real simple drawings. The infra-cochlear, so here's our cochlea, and we're going infra-cochlear, below the cochlea, okay, to get to the cholesterol granuloma. Most importantly, in this approach, which is done transcanal, the jugular vein and the carotid artery are two of the most important structures, are the most important structures, I should say, that we need to pay attention to. The infra-labyrinthine is done through a mastoidectomy. We do a simple canal wall up mastoidectomy, and we go identify the retrofacial air cell complex, surrounding anatomy, and we approach the Petrous Apex. This takes a little more drilling. This is usually not as much because when we're doing the infra-cochlear, we're much more anterior when we begin the surgery than we are when we do the infra-labyrinthine. And I'll show you this. So let's talk about the infra-cochlear. The most common procedure, if you're going to deal with a cholesterol granuloma, the critical anatomy for the infra-cochlear approach, as I mentioned just a short while ago, is the carotid, jugular bulb, the cochlea, the facial nerve, and the round window. These are important landmarks. So you can see the infra-cochlear approach is done through a post-auricular incision. We elevate a tympanomeatal flap, superiorly based on the malleus, because we need exposure to this whole hypotympanum. For those of you who have heard the lectures on the anatomy, the jugular bulb is in the hypotympanum other than in about 7% of the cases. And in about 6% of the cases, it's dehiscent. So if you have a high-riding jugular bulb, okay, it could be a very difficult case, and you might need to go middle fossa because you're not going to be able to go infra-labyrinthine. So assuming we have normal anatomy, what we'll do is we'll drill out the hypotympanum, exposing the air cell tract that sits between the carotid artery and the jugular bulb and is just below the cochlea, which is right here, the infra-cochlear. And here's our round window. So round window is important for identifying the position of the basal turn of the cochlea. And we have to be careful as we do this, the drilling of the hypotympanum for exposure, to remember that the facial nerve sits in the posterior canal. It can be just underneath the bone. So if you're going to do this, do it very cautiously. We come down here and we can see this is where the carotid artery is going to be, the basilar turn of the cochlea, the jugular bulb, and again, the facial nerve round window. So this little triangle, we create a triangular drilling zone between the carotid artery and the jugular bulb, staying below the cochlea. We advance it and we get into the cholesterol granuloma, and we put a silastic drain in it. So it drains into the middle ear, then down the eustachian tube. And that is a treatment for this. We bring our tympanomeatal flap back. Occasionally, we might have to put some fascia here to help support it. Occasionally, we might have to use some bone pate as well to build that up. It just depends how much of the hypotympanic bone you need to remove. And then we place gel foam. So here's a good video. This is the injections in the ear canal. This is this is an infra-cochlear approach. It's a left ear. We're making our incision to elevate the tympanomeatal flap. Then we'll put our Wheatlander in. There we go. And now we're elevating our tympanomeatal flap, which starts about right here from 10 o'clock to 2 o'clock. Again, we're going to have to pedicle it on the malleus. We need good exposure. And our area of concern here is to elevate the tympanomeatal flap and then expose the bone, expose the hypotympanum, identify the zone between the carotid artery and the jugular vein, or the jugular bulb, excuse me. We're putting a little piece of aluminum there so we don't destroy the flap by our burr. Drilling the hypotympanum now, opening it up for exposure. We're using either a 1 or 2 millimeter diamond burr preferably a coarse diamond. At this point, when we start drilling in the zone between the carotid and the jugular bulb, we'll use a regular diamond. After identifying the carotid and the jugular bulb, we will then proceed to begin drilling, and you can start to see that we're starting to get like a brownish color fluid, okay? Again, most important is that when you do this, you follow your structures. You follow the jugular bulb, you make sure you're not injuring the carotid artery. Once we've got the opening done, we put a silastic tube in, it drains into the middle ear, and basically we close. It looks like an easy surgery relatively, but like anything in otology, there is nothing that's easy. If it's easy, you're either doing the wrong surgery or you don't know your anatomy. All right, now we're bringing our tympanomeatal flap back. We have significant amount of canal skin, the drum's attached to the annulus, everything should just fall back into place. And if we're short, we can put, again, some fascia, a temporalis fascia graft there, and then the gel foam. So this is the standard infracochlear approach to the Petrous Apex. The infra-labyrinthine, below the labyrinth, through a standard simple mastoidectomy approach. Now here we have different anatomy that we need to know of. Again, really important on your CT scan to identify the position of the jugular bulb. A high jugular bulb, you can't do this procedure. You're gonna probably wind up going and doing a middle fossa or referring the patient to a neuro-otologist or a neurosurgeon. It's impossible, you're not gonna have the space. Should you be able to do this approach, the most important structures for the infra-labyrinthine are the posterior semicircular canal, facial nerve, jugular bulb, and the sigmoid. So here's what it looks like. We've done our simple mastoidectomy. We've identified the posterior semicircular canal, the facial nerve, the jugular bulb, and the sigmoid sinus. These air cells behind the facial nerve, called the retrofacial air cells, are what give us the access. They are the air cell tract that allows us to have a roadmap to the Petrous Apex. And just like the infracochlear approach, we need to follow our anatomic structures. We need to stay low down, follow the jugular bulb, and go anterior. If we go too high, the internal auditory canal sits in this zone here. It comes up to the geniculate ganglia, does a big turn here, and then comes into the horizontal second genu and the mastoid segment. So you have to stay low and follow the anatomy. So let's look here. We got a video and we're going to show the infra-labyrinthine approach. This is a right ear. This is the posterior semicircular canal. The facial nerve's already been exposed. And here's our sigmoid sinus. And it will go up here to form the jugular bulb. So we're opening up more retrofacial air cells here. Here's the posterior semicircular canal, the facial nerve, and as we drill, we follow our structures. We follow the jugular vein, the jugular bulb, staying close to on the sigmoid, and we drill. Again, this approach is much farther away from the air cells of the Petrous Apex than is the infracochlear. And eventually, carefully, using diamond burr, a lot of irrigation, we will enter the air cell tract and we will experience the same thing that we did in the prior surgery. And that is, we're going to get like this motor oil color, like a dark brown chocolate. And we do this very carefully. You can see we're drilling, we're stopping, we're drilling, we're stopping. Every time we do this, we're looking to see where we're at and what's just below the drill bit. Here's our brown fluid. Now we can take a curette or a little dissecting hook, and we can open this up if we prefer to use that method instead of the drill. Go slow, be careful, and here's our motor oil. So we're going to use this little pick and remove some of the surface bone which has been drilled here. Try to open these as wide as possible because there's always a potential for stenosis, either soft tissue or neo-ossification from rebone growth around it. And here we have the cyst, cholesterol granuloma cyst open, lumen being enlarged using a 2mm diamond burr. And you can see some of the granulation tissue down there. We're using a curette. And you have to be careful because the carotid artery can easily be exposed. The bone around it, from the cholesterol granuloma, can erode the bony covering in the Petrous bone so that your carotid artery and the cyst are abutting each other without any protection. Again, we're enlarging the opening. Careful. Everything is careful, paying attention to the noise of the drill, what you see, what you feel. And now we're going to put the silastic tube in, just like we did in the other case. And this time, instead of draining in the middle ear, we're going to drain into the mastoid. And then we close accordingly. So for just completeness sake, I'm going to mention the middle fossa for those of you who might not be familiar with it. The middle fossa is the approach to the floor of the middle cranial fossa, or the roof of the middle ear mastoid and the exposure of the Petrous apex. You have to have a special retractor to do this properly. And then when you do get this area exposed, and the retractor goes as far back as the superior petrosal sinus, you'll be able to see the geniculate ganglia. You will not see the internal auditory canal, even though this is where it's supposed to be. But you should be able to pick up some of the geniculate ganglia and the greater superficial petrosal nerve. As we go anterior to our dissection, we will pick up the third division of the trigeminal, and we have the arcuate eminence here, which makes up the superior portion of the superior semicircular canal. We have our cochlea. And now we have the region of the Petrous apex. Unroofing it, we'll get into the cyst, open it up, and drain it. But the most important thing is we need to remove the wall of the cyst. And again, you have to be very careful because in the zone between the carotid artery and the cyst itself, you can have absence of bone. And if you're aggressive, you can injure the carotid artery here, which would potentially create a stroke. And again, I mentioned this only for completeness sake. Dr. Solaris, August 4th, will talk about the approach, the endonasal approach or transsphenoidal approach via the sphenoid into the apex of a cholesterol granuloma lesion. This is a good chart because it kind of looks at the various approaches, the structures at risk, the advantages and the disadvantages. Any of you really want this, I'll be glad to share it with you. Just like any other surgery, there are major complications. There's lots of minor ones. We can tear the tympanomeatal flap, we can perforate the drum, we can, have a wound infection, but the major complications, such as facial nerve injury, are inherently important to identify and treat. In the infra-cochlear, you got to be careful with the posterior canal wall. With the infra-labyrinthine, it is mandatory that you skeletonize the facial nerve. So you need to know how to do that, what burrs to use, and lots of irrigation. Carotid bleeding. You can potentially get carotid bleeding when you're doing the infra-cochlear approach because the carotid artery is the main structure for your anterior border of your drill out. Equally, in both the infra-labyrinthine and the infra-cochlear approach, jugular bleeding from the jugular bulb or bleeding from the sigmoid sinus, as in the case of the infra-labyrinthine, can occur. And we've talked about this in the previous lecture I gave on, iatrogenic complications. You have to know how to deal with these, whether or not you're going to use just adrenaline with cotton, whether or not you're going to have to put bone wax, bone pate. You need to know how to deal with this. Sensorineural hearing loss. If you injure the cochlea when you're doing a infra-cochlear approach, you can potentially develop a sensorineural hearing loss. And fistulas. Fistulas in the infra-cochlear approach, you can fistulize the cochlea because it's the upper limit of your dissection, the basilar turn, or you can get a fistula of the posterior semicircular canal if you, in the infra-cochlear approach, if you drill the posterior semicircular canal too aggressively. So these complications are all real. If you pay attention, are concerned about the anatomy, and you know your anatomy, these type of complications should not occur. To summarize this lecture today, I think it's important to know that the anatomy is difficult. You need to know it cold. You need to practice on cadaver bones. All right, I have about 6 of these. I look at each one for variations in the anatomy and to understand the anatomy, because no matter how much unless you have a 3D mind or you're a savant, we need to look at these and kind of create the 3D image in our own minds as to what the anatomy of the temporal bone is. We talked about CT and MRI. They are critical for making the correct diagnosis. They're important for the design of the surgical approach and which one's going to be viable for the pathology that we're dealing with. And the anatomy and the pathology both dictate what approach we're going to use. And the complications are grave, especially of the carotid artery, and we need to know how to deal with that and manage it. You might have to take the patient to into the interventional radiology suite. They might need to, stent the patient. They might need to do another interventional procedure, but it's critical, and it's that you understand how to deal with the complications. All right, so that's pretty much my lecture on Petrous Apex. Think of it in that 30% of the patients are going to have a pneumatized Petrous Apex. Disease that occurs there is usually a spread from the middle ear or mastoid via air cell tracts, and utilize your radiology department, identify the disease, make sure you have the correct diagnosis, make sure you have the correct surgical plan, make sure you're competent in the anatomy, and I believe we can all do this. So I hope that today's lecture gave you an opportunity to understand a little more about the Petrous Apex and the role that you have in treating this